Good morning. This is Dr. Rutledge, and I will be talking about the MGB, about diabetes in thin patients, and about the MGB in thin patients, and about the MGB2. So let's get started. Okay, titled this Challenging the Status Quo because we're recommending you do things that nobody else does. So that reminds me of me. A surgical solution for severe diabetics and non-obese patients? No, I don't know if anybody's doing that. Can type 2 diabetes really be reversed? Well, I've said some radical things in my time, but that's pretty radical. Here's my email address. You can come back and get that if you want to contact me. Part of this was started after a patient actually came to our clinic here in India, Dr. Kular. A thin diabetic, 10 years post MGB, came in. She is 37 years old now, 67 kilos, and BMI is 25, so the normal limits. And her type 2 diabetes, HbA1c, when she had her surgery 10 years ago, was 15%, which is, of course, very dangerous and deadly. She also had hypertension, obstructive sleep apnea, hyperlipidemia, and migraines. She had been on insulin for 5 years, and prior to that, had been on oral drugs for 10 years, so 15 years of diabetes. She underwent a mini gastric bypass, which, of course, you shouldn't for a thin patient, but they did. And now her hemoglobin A1C is 4.7, which is, if it's not cured, it's really good. And that's a long time after the surgery. So that's a lot of years when uh, optic, her eyes were not damaged by an elevated sugar. Her peripheral vascular vessels not damaged. Her kidneys and her heart and her brain were not damaged by elevated sugar because it was normal. So we started looking at his data. So we have a new modest proposal here, which is early surgical treatment for diabetics. And we'll see if we can convince you that that's worth, learning about. Sorry. What we say, what we think, what we have the data for now is that the MGB2 and the MGB can now treat both thin as well as heavy diabetic patients. The MGB2, which we're going to talk about also, is simple, safer, 30-minute surgery, no staple line to leak or bleed, about half the cost, and improves or reverses diabetes. So we'll be talking about all those things today, I hope. This is the MGB2. It's a very good treatment for diabetics, especially thin diabetics. And it's um, got a 30-minute op time, same day surgery, no staples, oh, and half the cost or less. Imagine a proven treatment for diabetes in thin diabetics. We're going to see that Kular, Manchanda, and myself are reporting the case where 55 patients did just that. So we'll talk about that in just a moment. I want to point out that there's a worldwide crisis, a pandemic of diabetes with blindness and kidney failure, amputation, heart attack, stroke, death, and liver disease. And we think that MGB2 might be a solution. So stick around. So less than 30 minutes, no staples, half the cost. That's what it looks like post-op. These are the tragedies we're trying to prevent. And higher low, higher HbA1c is bad, and diabetic complications go up. And so we can stop that. And HbA1c is a powerful predictor, so we're going to use that to predict how many lives we save, etc. So what can we do for diabetics? Well, drugs often not so good. This is the delta hemoglobin A1C. In those cases, many times it's not anything more than 1% of HbA1c, and it costs a fortune. So you're paying a lot and getting a little. Drugs can sometimes help, but what else can be done? Are there any other options? And so what we say is yes, there is an option. That's what we're talking about today. And I'm not smart, but we've known for 100 years, actually, there is a solution for diabetes, which is the Billroth 2. And of course, that's all an MGB is a Billroth 2. But a Billroth 2 gastrojejunectomy with cholecystoplasty was a bit long in those days, so we shortened it. But there's a lot of data that basically proves that a Billroth 2 does either improve or reverse diabetes. And these are just some of the papers. Now, why does Billroth 2 resolve diabetes and frequently sleeve patients doesn't? Is because one of the most important parts of the body is what you see here. That's the gallbladder, the liver, the pancreas, and the duodenum, all of which are designed to catch the fat as it comes in and help digest it. You and I are mostly water. And so what that means is we can't easily digest fat. Oil and water don't mix, but you have this location where we mix in these detergent systems from the gallbladder primarily, but that helps us digest those fatty, greasy foods. And when we do a Billroth 2, that's interfered with. So the saturated fat, which now has been shown to cause diabetes, is interfered with, and the diabetic patient gets better. So here's the data from Dr. Kular and Dr. Machenda, and they reported successful long-term surgical treatment in thin diabetics. So the preoperative hemoglobin A1C was a very high 12.6, and postoperatively, the mean is 6.1, which is not quite normal, but right next door. So preoperative 12.6, postoperative 6.1, magic from MGB. And here's what we see here graphically, 12.6 pre-op, and then watch this, 7, 6.7, 6.4. So even up to year 6 post-op, still going down. In other words, it's not like a short-term fix. As far as we can tell, it is an ultimate fix, although we'll have to watch longer. Same thing again, but look here, 6.1, below 6 is getting normal. So here's again, just to look at it, the years 1, 2, 3, 4, 5, 6. So 7, 6.7, 6.4. So every year that passes by, instead of looking dangerous like it's going to come back, it looks like it's just getting better and better. You can't ask for a better treatment than that. One-time treatment. Yeah, there it is. So what do we see? Well, for example, in this series, 85% of patients were taking insulin, and at year 7, 8% were. In other words, let's stop and think about that. Up to half of patients who are ordered to go on insulin refuse or delay, and they can delay for 10 or 20 years, and that can lead to deadly complications. Similarly, those on oral anti-diabetic drugs, up to 80% pre-op, and post-op, 10%. So this treatment is fantastic, if I do say so myself. And here, let's give another graphical picture. Here's everybody else except for these 3 Lone Rangers. They're the only people that are still above 7. And below 7 is tiger country. That's where you do well. So this is that same graph. 1, 2, 3, that's it. Everybody else is in you can't call it cure, but that's a happy zone compared. Here's some more data, which basically the longer you wait, the less chance you have of resolving your diabetes. So here, these patients are in the normal zone. This is very good. And that's because they're young. So I think our conclusion thus far is that means operate early, don't delay. Another question is, what about malnutrition? Everybody's worried about malnutrition if you do an MGB or something like that. And in these patients, not only did their B12 not get too low, but it actually came up. So in other words, after the surgery, they had better various measures of nutritional value. They ate better because they ate less fat. They were diverted from eating fat. So their risk of malnutrition went down, which is a lot of confusion amongst critics of the Billroth 2. Here's another example. This is a calculated risk of amputation. So let's imagine for a second that based on many studies, we have data that says if you have a high hemoglobin A1C, let's say down here at greater than 8, you're very likely to face an amputation in your later life. In this series, the numbers we used, it came out to be almost 3/4 of patients would have to have an amputation. And after the surgery, it's down to 2.8%. So we save legs and lives. This is an estimated health cost from another published series on how much it costs based on the HbA1c level. And here you can see that there are thousands of dollars per year calculated in excess cost because they're sicker. And it's not every patient, but the average patient costs a lot of money if they're sicker with high elevated HbA1c. Another thing we looked at is, well, everybody says, your patients will lose too much weight if you do a Billroth-2. But that's not true of Billroth-2 patients in the published literature. It's true if you don't know how to bypass or how much to bypass. And what we see here is a normal hemoglobin A1C, a normal BMI range for these mostly women is between 18 and 25. And all of our post-op patients are almost all between 18 and 25. And there's no one that's too low. And there's one that's slightly above, but still not in the morbidly obese or anything like that category. So in other words, if you use these measures so far that I've shown you, it's perfect. So the MGB is nothing more than an MGB2, and we have almost 100 years of studies that show that the MGB and the MGB2 resolve diabetes or improve it. This is another study which just shows basically operate soon rather than late. Okay, let's do an MGB2. Basically, it's simple. Billroth-2 plus a gastric plication is a MGB2, and a Billroth-2 plus a Collis gastroplasty is an MGB. So let's look at it. It should look exactly the same. So we're going to say here's the Ewald tube coming down. That's the location of the old gastrojejunectomy in the MGB. You find the greater curvature, then go to the ligament of Treitz, bring the ligament of Treitz bowel up here after running the bowel, which usually for a short bypass is around 1 to 2 meters. And then we anchor it and put a stitch in, and then we staple a gastrojejunectomy and close that. That's it. And but you'll notice a very large efferent limb. That's what you want, and a very smaller afferent limb. So I'm sorry, I got that backwards. Large afferent, small efferent. Excuse me. And then we plicate the stomach, and just a couple of stitches, and now we have the plicated stomach, 2 layers, and the afferent limb, the antrum, plicate the antrum, and we're done. So, radical, quick, thin diabetic, double your practice volume with all the diabetics that need surgery, 30-minute op time, same day surgery, no staples, cuts the cost. That's the end, and be happy to answer any questions.